Thank you, and it's so great for me to connect with all of you. I know many of you, I see many familiar names and faces, so thank you so much for being here. And the purpose of these meetings is for me to be able to connect with you and answer any questions that you may have about primary lateral sclerosis. So specifically, this is going to be about PLS. As you know, myself and other colleagues really want to keep PLS front and center and make sure that we continue to make progress for PLS. So before I take your questions, a couple of things. I think a few questions were submitted in advance, but I think we can also start. Norma, you'll help us, right, with the sort of the chat. So feel free to write any questions you may have about PLS in the chat, and then Norma will ask the questions. I do want to make a couple of announcements, which I think are incredibly exciting. So first of all, thank you to all of you and the Spastic Paraplegia Foundation for providing prizes for the best PLS research that will be provided at the annual ALS meeting in Florida. We have an annual meeting that generally focuses on ALS. That's the meeting of the NEALS Consortium or Northeast ALS Consortium, but we want to keep PLS front and center. Why is that important? Well, because as you know, PLS is not ALS, but it shares a lot of common parts to it. Even if people, have a very different disease, some of the mechanisms and the biology is shared. And because there is a lot of research in ALS, we want to leverage everything that we learn in ALS and directly and quickly apply that to PLS. So for example, some of you kindly send me papers, about research in ALS and breakthroughs in ALS, and can we actually apply that to PLS? And the answer is that we need more attention to PLS. We can definitely learn a lot from ALS and apply that to PLS as quickly as possible. So the fact that the foundation is sponsoring research and awarding these prizes, two poster prizes for the best basic science research and the best clinical research, this is really important to catalyze the field so that more people continue to do research on PLS. I would say one of the reasons why research on PLS has been a little slower, over the last several decades is because there hasn't been enough funding, but the SPF has been changing that. And in fact, now that we have these awards, I feel like we're going to continue to see more progress. So that was the first piece of news. So thank you, Norma, for the prize. So anything you want to share about that?
No, I think you've pretty much covered it. We're going to try our best to get someone in that area that can go in and give that presentation and represent us. So that is wonderful.
Yeah, that's great. And then so the other piece of news, the second announcement I wanted to make today, and I'm very excited about this as well. You may know that, just like we have our US-based annual conference on ALS every year, there's also another conference that's, very important for ALS research that's global, meaning that, people from all over the world attend that particular conference. It's a global conference. So it's called the International Motor Neuron Disease Symposium. It happens every December and it travels around the world. For example, in 2025, it will be in San Diego. In 2024, it was in Montreal, Canada. And the reason I bring this up is because historically, this International Motor Neuron Disease conference is mostly focused on ALS, again, because there are more people with ALS, and so there's always been more funding and attention to ALS. Now, you may remember, if you've been following, SPF News and maybe this webinar series, you may remember that 1 year ago, almost 1 year ago, in December, we met in Montreal, and I see a few people on the line that were there actually at that event. And we had a dedicated day on PLS that was spearheaded by Dr. Hiroshi Mitsumoto at Columbia University, and it was really my honor and pleasure to help him put together the PLS conference in 2024. And we have a paper that's available open access if you want to read it, if you want to see the summary of that, that's available. The SPF kindly has a blog, so all the information is freely shared. The reason I'm talking about the conference that happened in 2024 is because it was so successful then this year, for the very first time, we're going to have the opportunity to have a dedicated session on PLS inside the main ALS conference. And I think that that's really huge, because that means that it will attract literally hundreds of researchers who are there for ALS, and we're gonna convince them to do more research on PLS. And this really stems from the success of last year's conference in Montreal. Actually, the Spastic Paraplegia Foundation supported that conference as well. And now that led to the organizers of the main conference to now include PLS as part of the main program. So not as a satellite meeting, which was great, but it was just, for people who were already interested in PLS. Now it's going to be part of the main conference. So our goal is to attract as many people as possible to from ALS to PLS. And again, because we're part of the main track, I think that's going to be possible. And we're trying to put as much effort as possible into this meeting. And the reason for that is because if it is successful, then hopefully it will become a standing feature of the ALS conference. So I just wanted to take a moment to thank you again at the Spastic Paraplegia Foundation. You have really been instrumental and critical because of your work. Now we have this great opportunity to be part of the main meeting, which I think will literally attract hundreds of people. And that's really needed in order for us to make more progress. So I'll just stop there, and thank you, Norma, for your support during last year's conference. So that really catalyzed a big change.
That is so wonderful, Dr. Paganoni, because this week, we've actually, as a part of our activities, we're going to let folks know during Awareness Week that on August the 27th, that is our USA Day that we celebrate and bring awareness to HSP and PLS. So we try to do all that we can. But on August the 27th, we're actually going to be modifying that because we are working with our international partners, and we are going to make a World Day on October the 17th annually. So we've got this big push that's going out with our international partners because we have like 65 countries that are represented in our database that have HSP or PLS. So this is a world thing. So we really very much appreciate the idea of the international meeting having that one section for PLS. So thank you for all your hard work on that.
Yeah, thank you. And now what I want to do, really what I want to achieve, is to make that a standing portion of the meeting. So again, this year it's the first time. So hopefully there will be more. And I'm going to try to understand if people can participate remotely. So let me work on that with the conference organizers, if there's interest in joining the actual PLS session remotely. I don't know exactly if that's going to be possible, or perhaps the recordings. Let me work on that, and more to come on this. So again, we want to continue to catalyze progress in PLS.
That is wonderful. So there's questions already backing up in the chat room. Do you want to take those, or however else?
Yeah, maybe we can start there. Do you want to read the questions, Norma, or take them as they come?
Yeah, you can take them as they come if you would like to.
Oh, okay, sure. So I'm going to start with the first question. So there's a good question about whether PLS has a plateau. So ALS is progressive and PLS is a little bit different. And the question is there a plateau for people living with PLS where progression may stop or slow down? And when does that happen, or how often does that happen? And so thank you for asking the question. The person who's asking says, I'm 4 years since diagnosis. So want to learn more about this. So yes, there seems to be a plateau at some point for many people with PLS, which is different from people with ALS. Now, even in ALS, studies have shown that for any individual person who has ALS, there may be periods of plateaus. For example, up to 25% of people with ALS may experience a plateau, meaning no progression over a 6-month period. However, after that, most people will continue to progress. PLS is different. So in PLS, we see a slower progression overall, and also many people have reported a plateau. So you are exactly right. Now, obviously everyone is different, so this may not apply to every single person. But what I've seen from some previous natural history studies is that the disease seems to slow down, especially after about 7 years after the initial symptoms. So it seems to be like, people will experience a progression and then a little bit of a stabilization. There could still be progression. I'm not saying that it will stop completely, but some natural history studies have suggested that there may be, again, a slowing down at some point. I will say the results of the natural history study of PLS that Dr. Mitsumoto has been leading for the last few years, are being collated and right now. So hopefully we will know more, and so we can give you more specifics as the results are published over the next few months. Now, there's another question about diagnosis. So obviously, it's important to make sure that people with PLS receive the right diagnosis. And I think there's also another person who also said, I've been diagnosed misdiagnosed, I'm sorry, more than once, right? And so, so again, I guess to put together all these questions, how do we make a definitive PLS diagnosis, and is there the possibility of misdiagnosing PLS? Yes, I mean, diagnosis is, a big issue in PLS, and there are many reasons for that. So first of all, because as you all know, PLS only affects the upper motor neurons. However, over time, things may change. And so we need to, if you use the historical traditional criteria, we need to wait for 4 years after the initial symptoms to be able to be relatively sure that the diagnosis is PLS. So that's the first problem, that even if you do all possible tests, even if you see the best doctors, even if your case is sort of typical, by definition, by criteria, by the textbook criteria, essentially, you cannot fully confirm a definitive diagnosis of PLS before 4 years from the initial symptoms. And obviously, we know that the initial symptoms may be subtle, so sometimes it's hard to know exactly when they started. So it's already complicated. Now, in order to make the diagnosis a little bit faster, actually, there's been new diagnostic criteria that were proposed in 2020. And now we're in the process of validating and making sure that those are correct. But essentially, the new criteria suggest that after 2 years, you can call PLS probable if you have certain features, and then you still need to wait for 4 years to say definitive. So at least it's a little bit of progress in the sense that a new category of probable was introduced. So essentially, according to this criteria, if somebody has a PLS-like presentation affecting only the upper motor neurons, in theory, you can make the diagnosis already 2 years, but it's going to be called probable. And then you still have to wait the 4 years to be called definite. So unfortunately, we don't have a way to diagnose PLS faster than that. And again, I don't know, Norma, if you can maybe circulate the paper that was published from the conference that's available open access, so that if people want to read more and see, that could be something maybe to be circulated. Do you have it handy, Norma, or do you want me to send it to you?
Well, go ahead and send it to us so that way we've got for sure. But I think the document that you're referring is already on our website. And I think the conference video is actually already on
Yeah,
our YouTube channel.
yeah, you're right. You're right.
Yeah.
So those are there. Yeah. Um, so there's a question. Let me just read this for a second. So that's a good question about does PLS moves around the muscle? So for example, there are some spasms in one place, if I understand the question, some spasms or some weakness in one place, and then that improves a little bit, and then it moves to a different area. So that's an interesting observation. That's not something that I hear that often, but I will say that some areas could be more affected than others. And so over time, things may change, that for sure. I don't know if I'm fully answering your question, but feel free to type again in the chat. Or I think people can also mute themselves, right, Norma, if they want to
Yes, they
ask a
can.
question.
Yeah, if they want to, if you guys want to ask a question, feel free to raise your hand or shake your hand, and I'll call on you guys. So feel free to do that. There's the little button at the bottom that lets you raise your hand, and that way it puts it in order. And here is Joanna. Go right ahead, unmute yourself, dear, and go right ahead. Perfect timing.
Thank you. Hi Sabrina. So
Hi.
so yeah, of course I'm so strange. I have my normal spasms and spasticity, and yet in the winter I often have new and different spasms. But I have a new trick now. During sleeping, my left ankle spasms inward. Um, how long is it going to do this? I don't know. So far, it's been 3 weeks. Will it last for 4 or 5? I don't know. I suspect it will go away again at some point. All the other winter based tribulations often go away, and I get back down to my regular normal. But I don't think there is a normal for any of us with PLS, really.
No, that's a good point. I mean, you're pointing to a correlation with winter months that obviously, depending on where people live, may be more or less pronounced. Obviously, for all of us in the Boston area, there's clear variation over the months. There's you go from literally minus 10 to 90 degrees in from going from winter to summer. So that I would say if you live in a latitude where there are these clear variations based on the season, that I've heard a lot. In fact, I mean, I will say I know some people with PLS who actually escape from Boston in the winter months because they know that that's not a good fit. And so that for sure. So I would say the seasonality or temperature related excursions are actually quite a common phenomenon. In terms of what you're describing about, if I understand, kind of the ankle turning in, so I would say that that's also, for people who have some increased tone or spasticity or spasm, one of the common, there could be spasms everywhere in the body, but I would say a common one is what you are describing, which is the inward motion at the ankle. That's definitely, and kind of also kind of curling down the toes. And that's, interestingly, it tends to often happen at night. I know it sounds crazy because of the weight of the blankets and kind of, just because normally when we sleep, for everyone, everyone tends to assume a certain tone, like more flexed, let's say, or more inward, and that's kind of normal for everyone. And then, if you have an upper motor neuron issue underlying this, basically it will tend to curl in. So that's kind of a common area for spasms, at night. Some people will use special socks at night, or even soft braces at night to keep the ankle in a certain position. That could be one option. Yeah.
Dr. Paganoni, there's a couple of questions about what is your perspective on using Keppra to help with spasticity or amantadine?
Yeah, so those are good questions, and I see a few other questions about other therapeutic modalities, anything ranging from supplements to hyperbaric oxygen therapy. So I would say that all of the things that are mentioned in the chat, including again oxygen treatment, amantadine, or Keppra, all of these are have been reported by people living with PLS, and so I want to be respectful of everyone's obviously experience and personal response to these treatments. They are not backed by scientific studies per se. In other words, there haven't been large enough studies to fully put kind of a number and really translate these individual experiences into observations. This does point to the need to do more studies. So there was, for example, there was a study of Ampyra, as you may remember, a few years ago, trying to see if it can help with gait. There's never been a study that I know of Keppra or amantadine. Absolutely would be important to do that. I also understand that different people may kind of respond differently. And I think there is a hand. Is that
Yes.
somebody's raising?
Lana, unmute and come on in. You got to unmute, dear. You got to unmute. We can't hear you. Unmute your computer.
Are you talking to me?
No, we were talking to Lana Kaufman,
Okay.
but who just spoke? She can't get her unmute button. We can't hear you.
Okay, can you hear me?
I can now. Go right ahead.
Okay. I was recently pres- prescribed Valium for the spasms and the pain, and it miraculously worked.
Oh,
What do you think?
Absolutely. So let's say that there's two big categories. So there's, a few medications like the ones that were mentioned earlier, like, Keppra, amantadine, etc., that are more, they're meant to help with some aspects of the disease or slow down the disease. Those are not approved necessarily for PLS. There's a whole different class of medications like Valium, baclofen, tizanidine, or Nuedexta, which is in the chat, that are, have clear FDA approved indications that are applicable to PLS as well. So for people who have spasms, spasticity, baclofen, tizanidine, or Valium is, if needed, can be used. Now, Valium has other, it has a certain side effect profile, so I cannot comment on whether, it can be applicable to everyone with PLS, because in fact, one needs to be careful about certain medications. So I would say every medication has specific side effects and interactions. So, I assume you're getting that from your doctor. And so, based on the conversation, your specific medical history and disease, obviously that seems to be working, which is great. But again, everyone will have a different presentation. And so you need to talk to your doctor. But that's one of the medications used for spasticity, absolutely.
I'm on, can you hear me?
yes, dear. Go ahead.
Okay. I'm on tizanidine and baclofen, but I only take the Valium at night to sleep, and it's the first time I've been able to put the sheets on my feet.
Oh,
That's great. That's great.
wow.
Yeah, I would say that most people will prescribe tizanidine and or baclofen or both, like in your case, for spasticity. Those are generally the first line medications before going to Valium. The reason for that is really the side effect profile and the potential for dependency of benzodiazepines such as Valium. So like exactly what you are describing, most physicians will try to manage spasticity with tizanidine and or baclofen or both. But if that's not enough, additional interventions could be considered depending on your own specific situation, such as Valium, which seems to be working in your case, which is wonderful.
It's only 2 milligrams, and it's working.
That's good. Yeah, no, again, everyone obviously has a different, different other medications or other diseases. And so I would encourage, if you feel like, you need better control of the spasticity, obviously you can talk to your doctors about what else can be added.
Thank you.
Yeah, welcome.
Dr. Paganoni, there was some questions on here about folks asking about supplements, maybe B12,
Yeah.
that, hyperbaric chamber oxygen therapy.
Yeah. So all of those, are not fully tested for PLS or for motor neuron disease. So again, I put them more in the category of those are things that, some people may have tried and may have, reported benefits, but again, to be clear, they've not been tested for PLS. That's different from baclofen, tizanidine, or even Valium if needed, as we just discussed, because those are more kind of part of the sort of the regular set of medications that are used. And before, I know somebody has a raised hand. Before we go there, I also wanted to take the question about Nuedexta, because that's also in the class of medications. So there's a question about, can Nuedexta help, for example, for PBA or pseudobulbar affect, or also speech and swallow? Absolutely. Nuedexta has been approved for the treatment of PBA. In my experience, what I hear from patients is that it's quite effective for PBA or pseudobulbar affect. It's not approved for slurred speech. However, some people report a little bit of benefit on speech. Again, not approved for that particular use, but I heard that too, that some people, not everyone, some people report a little bit of benefit. So again, there's, to me, there's also like a difference between things that surely work and work for certain symptoms and other things that may work and need more research. There's very two different camps. Yeah.
Thank you for clarifying that, Doctor, because we've got a spot on our website that we're trying to capture that information from our membership that says this is what we've used, this is what's going on, this is how this has helped. And then we also did a survey where 800 people provided a response, and we're collecting that data right now. We're going to have that available at the conference and as a downloadable document so that we can see what other people have used or are using for their medication for their particular symptoms. So that's good. And we need to capture that and let other folks know that these are also things that our families here have tried.
Yeah.
Joseph, you got a comment or a question? You want to go ahead?
Yes, the study you did a few years ago, the MRI PET scan, that, show inflammation in different parts of the brain. Is that still ongoing, or did it all work out?
Yeah, in fact, we have a paper published on, first of all, thank you for following our research. And yes, that was also funded by the Spastic Paraplegia Foundation. And we have a publication that's available open access about the pattern of inflammation in people with PLS. So there seems to be a specific pattern of inflammation, neuroinflammation in the brain in people with PLS, which is different from ALS, number one, and also is not present in people with HSP, also known as hereditary spastic paraplegia. So the study worked. The only challenge is that that particular test is still a very special test. So it's hard to access, and it's also very expensive and requires specific research grade equipment. So it's not something that's broadly clinically available.
Where do I get a copy of the study?
Let me send a couple of studies to Norma, and maybe, Norma, if you don't mind circulating them, and also maybe again on the website. I think both are on the website anyway.
Thank you.
Yeah, thank you, Joseph, and thank you, Doctor. That's wonderful. We'll get that information and make sure that you guys have access to that. But in the meantime, go look under Dr. Paganoni's name on our website, because what we've been doing is actually grabbing all of those links, all those documents where possible, and we have that information available so that you guys can link to that.
Yeah, and I do see other questions about sort of other medications. So for example, Riluzole, is that recommended for PLS? I mean, that's another great question. This is one of those drugs that falls in that kind of, oh, we really don't know. It's been tested in ALS. It's approved for ALS. There's been no testing in PLS. And so that's one of those situations like before, where, I'm not saying that it cannot work. I just don't have the evidence for it. So it's more a conversation between you and your doctor to discuss what to do about Riluzole. The other question just below that is the Botox injections to the ankles that can stop the cramping. Absolutely. Botox is indeed approved for certain specific symptoms. Again, one would need to decide to discuss, again, side effects. Is it, is it needed? Where? How much? So these are all details to discuss with your doctor. But that's more in the Botox is more in the camp of medications that for sure are approved to treat spasms if needed. But again, it's more in, if they can be managed with other medications, obviously it's easier.
That's one of the things, Dr. Paganoni, that we've been talking about at the foundation, is that there are a number of medications that are available for like Parkinson's or MS or, cerebral palsy or there's a whole list of them, right? But there's none that's really dedicated to HSP and PLS. So it may be that it helps a symptom, but then yet our doctors are not going to prescribe those because it doesn't say somewhere that it could be available for some patients that have HSP and PLS. And that's one of the things that we're really going to be talking to the National Institute of Health and FDA as we start working on our conference in October when we go to Washington, D.C.
Yeah, let me just go back up because I mean, these are all great questions. And I have to say, I really love how the PLS community is always engaged. We oftentimes get questions before the meeting, but then we have so many excellent questions. It's, it's wonderful here. So there's a question about HSP and PLS. So obviously the Spastic Paraplegia Foundation provides, support, funding, awareness about both, HSP and PLS. So they are both diseases of the upper motor neurons. And I believe that that's why historically the SPF has been, working on both. And it makes sense because both are diseases of the upper motor neurons. However, they are different in many ways. Number one, HSP is more frequent than PLS. Second, HSP is more often genetic than PLS. And that's not true always. We have people with HSP who have a family history. I see a few comments about that in the chat and have an identified genetic mutation in the family. But it doesn't have to be that way. Some people may have HSP and the gene for that particular form of HSP may have not been discovered yet. So a negative genetic test will not rule out HSP, although obviously if you have a positive genetic test, then obviously you're sure it's HSP. PLS very rarely is genetic. There's been a few occasional cases that have been reported, but most people with PLS don't have a genetic form. So that's another difference. The other big difference is that, generally speaking, HSP affects the legs and not much else for the typical cases. Now, there are some atypical cases I will say that also affect other parts of the body. So again, I don't want to be too absolute in that statement, but sort of if you think about the most common presentations of HSP, again, most commonly it affects the legs. And for PLS, generally speaking, it affects also other parts of the body, including, for example, speech, which is something that's more rarely affected in HSP. Again, these are not absolute statements. People can be different. There's different forms. There's atypical cases, but that's kind of in general. So those are the differences. Now, because HSP is oftentimes, not always, but oftentimes associated with a known gene, there's been some progress, which is quite exciting in terms of developing genetically targeted treatments. In fact, I see a question from somebody living in the Boston area, and I would say that at our hospital at Mass General, we have one of the world's leaders in HSP, Dr. Craig Blackstone. And the reason I'm mentioning him right now, and I know he works a lot with the SPF, the reason I'm mentioning him right now is because thanks to the SPF and the really great support from the community, he now has an HSP clinic. So if you're looking for an HSP doctor, especially in the Boston area, I would highly recommend Dr. Craig Blackstone. I'm sure he's been a speaker at many of your conferences, so I don't have to introduce him. But specifically, he also works a lot on genetics. And so if you're looking for people that can connect with pharmaceutical companies or other groups trying to develop ways to turn off genes for specific forms of HSP, I would say that definitely connect with Dr. Blackstone. And so that's also a difference, right? Well, for HSP, kind of the therapy development is going a lot towards genetic interventions. For PLS, because most cases are not genetic, we had to look elsewhere. And that's why piggybacking on progress in ALS is so beneficial, because there is a lot more research on ALS. And so hopefully now by bringing PLS to the forefront in ALS circles, hopefully we'll be able to get a little bit more attention and get some of the drugs that are being developed for ALS, we'll try to repurpose them from PLS. And I know that obviously everything takes time and I wish we could do that sooner, but I will say that I'm very excited about last year's conference and now the follow-up. PLS being front and center both at the national US-based consortium meeting and also the international MND symposium, I think that's really the right step in the right direction to make that happen.
And that leads right into a profound question that Bruce asks, and he says, why symptoms and progression so diverse in a single disease?
Yeah, no, that's really a conundrum. I would say, it's possible that, when we have a single disease, we're actually talking of many different diseases that kind of look similar to one another. And that's why people are different. So if you think about HSP, let's think about a different disease. HSP can be due to, I think, 80, 90 different genes that have been discovered and more that have to be discovered. And so the same disease is really the result of many different mechanisms, many different genes that have nothing to do with each other. But then, people can have the same disease and yet be a little bit different. So some people with HSP, as I said earlier, have pure leg symptoms. Other people may have a little bit of a more mixed presentation. So yeah, and that's probably because many different genes lead to the same disease. And so while we call everyone HSP, the reality is that you could think of every single gene as a different disease in a way. And so in PLS, we don't have that genetic correlate. So I cannot say, oh, this person with PLS is, has a different gene and different mechanism compared to the other person with PLS. But the reality is that there could be different mechanisms that we don't know yet. And so that's why some people look one way and other people may progress a different way, because while they all are in the same kind of group of PLS, really their disease may be different. So it's still something that deserves a lot more research.
And that, Dr. Paganoni, has really been kind of the conundrum, as you said, is that trying to get our hands wrapped around everybody that's got, it's like everybody's got different hair, right? Or some people have no hair. But it's a matter, as far as the foundation is concerned, how do we get our hands wrapped around what's going on with our population and our families and our communities? And I think it's got to come back to where at this point, at this stage, is what symptom is the worst symptom that I'm dealing with? And how then do we try to get that symptom relieved from our bodies and hurting us so badly? That's where science is going to have to head, and that's where we're going to have to see where we go from here. So Patrice, you're with us, so please join us with a question.
I saw my neurologist, Dr. Fink, who you probably know, in Michigan recently, and I asked him the question about whether, like stroke, when you have a stroke, you often hear about the brain kind of rerouting or compensating for the stroke. And I asked him about PLS if he thought, I realize it's a different injury, but he thought absolutely that your brain was trying to compensate for the PLS. Have you seen that, and what are your thoughts on that?
Yeah, no, I completely agree with Dr. Fink. In fact, even, I do a lot of research also on ALS, again, a different disease that's much more rapidly progressing. And a goal of a lot of the research in ALS, believe it or not, is to slow it down. And PLS is often used as an example. We would want to slow down the disease in ALS to make it look like PLS a little bit more, so that, when the disease slows down, that's when you can have that sort of plasticity or rewiring or regeneration. And I wonder, and this is just my speculation, I don't know if that's true, I don't think there's any research on this. I wonder whether that's why some people, at least some people, report the plateau that we were talking about at the beginning. Yes, PLS happens, but then after a few years, it kind of slows down. And maybe it's because that process is happening. Again, I don't know for sure. We need more research, and nobody has really demonstrated that. But many people assume that because the disease is slower than, again, ALS, and I completely understand it still progresses and affects people's lives, so I don't want to minimize that, but relatively speaking, it's slower than ALS, and that gives people with PLS the opportunity to rewire a little bit, and that's why some people, fortunately, have at least a plateau after a few years.
That's very interesting, Patrice, because even Colin makes a comment here about six months ago he had a stroke, and it turned out the cholesterol was very high, but it's being managed now with a Mediterranean diet and an aspirin each day. While I understand that the stroke is not associated with PLS, I'm wondering if it had hastened the progression of motor neuron disease or if the PLS will limit the recovery from the stroke.
Yeah, I mean, in general, we say that, whenever there is an injury or another coincidental issue, whether it's a fracture or a stroke in this case, or other things, oftentimes it takes longer to have to do rehab for people who also have a different disease. And that's kind of a general principle, because the body is already trying to, to compensate and do the best that it can to deal with the primary problem, let's say PLS in this case. And then, when you have another problem like a stroke, it may take a little bit longer. But again, that doesn't mean that PLS will affect that directly. It's just that, kind of that now there's two things to deal with. So I hope that, it sounds like from the message that the stroke was mild, fortunately. So hopefully, again, your body will be able to manage that soon.
There was a question here I was going to ask you about, but now I've like morphed and lost it. So I apologize. Here it is. It's from Susan. She said she had a knee replacement. She hasn't gotten back to the level of functioning. I also have a diagnosis or HX of falls. Is it possible to develop into ALS later, 20 years after being diagnosed with PLS? So there's been some kind of common discussion about, am I diagnosed with, PLS, and then is it possible for it to then morph into ALS?
So a couple of things that I do want to take again a moment to talk about the knee replacement, and that's kind of aligned with what I was saying before. When you have another problem, let's say you have PLS as the primary problem, and then you have, a stroke in the case of the other person, or in this case, knee surgeries or problems. That's the question and the follow-up comments. It may or may not take you longer to do rehab for this sort of secondary problem or the other problem because of the underlying PLS. However, it is definitely possible to recover completely from something else that can be, fully recovered, like a knee replacement, for example. So it depends a little bit. It's not I guess what I was trying to say is that it's not uncommon to have to take a little bit longer to do the same rehab. That doesn't mean that people will never get back to the same level of function, for example, after a knee replacement, but it may take a little bit longer. That I've heard from a few people. In terms of, can PLS develop into ALS later? So let's talk about the timelines. So as I said earlier, in order to make the diagnosis of PLS, by definition, you need to wait at least 4 years after the initial symptoms. And that's when, based on available research, the reason the 4-year cutoff was chosen actually is because if people develop ALS after initially being, having kind of a PLS presentation, most of the times, in the great majority of the times, it happens during the first 4 years. So if somebody is destined to develop ALS, they'll do so within 4 years from the first symptoms. Now, it's not impossible, for full transparency, it's not impossible to develop ALS later, but the chances are very small. And so that's why, the 4-year cutoff has been, selected. Again, it's not 100%, but it's more, it's kind of, less likely to develop ALS later on.
Does TMS show abnormalities in PLS?
Yeah, so in fact, as part of the PARA study a few years ago, we did a lot of TMS in people with PLS, and because the disease, is slowly progressive, and people have it for many, many years. In fact, it does not affect life expectancy. So because of that, the TMS, which is essentially a way to measure excitability of the neurons, we often found that it was hard to record actually from people with PLS. And that doesn't mean, anything for you specifically. It's just, a lab test to show that the excitability of the nerve cells, changes over time as expected. So, I mean, I wouldn't be concerned about TMS results in particular, because it's not something that tells you anything else. I guess what's important is obviously how people feel and their symptoms. TMS is just a lab correlate of that.
There's a very interesting question. Do you think that as it advances, will, AI will eventually play a role in figuring out and the cause and cure of ALS and PLS? There's such a thing going on right now, right, with AI?
Yes. So, I mean, there's a lot going on. I would say that, AI will have a lot of impact, or is already having a great impact on many aspects of healthcare and research. So absolutely, if you ask, the broad question is, do you think that AI will have a role in figuring out ALS and PLS? I would say absolutely. I mean, I think there's very high chances, because now AI is being used in so many different aspects of the research that it's bound to do something, right? I mean, it's basically used, for example, just to give you a few examples of things that are very disparate, like, in the preclinical labs, in the scientific labs, we have people now who are using AI to screen drugs faster than it was possible to do before. So that's one way, just, you have more shots on goal, essentially. You're screening more drugs faster because with some AI algorithms, you can do that. That's just an example. Another example is that, AI can be used to help recruit people and identify people that are eligible for trials faster. So at the other end of the spectrum, after you have screened for drugs, how can you actually test it faster in people? You can use AI-based recruitment strategies or kind of operational paradigms to do that faster. So it can really affect a variety of aspects of the research process. That's what I'm trying to say. So AI is not just one thing, but it's like a series of applications that are going to continue to, I think, permeate all aspects of our life, including research, again, from the basic science to more the clinical science.
Dr. Paganoni, I want to remind you that you've got about 4 minutes left on your time schedule. And thank you so very much for joining us today. So there's one question here that says, what is TMS?
Yeah, it's transcranial magnetic stimulation. So it's a way to test the functionality of the upper motor neurons. And that's obviously of relevance for people with PLS. And you may have heard of EMG. That's like a nerve, it's a test with pulses and needles that go into the muscles. By definition, that's only testing the lower motor neurons. So for people with PLS, by definition, EMG should be normal, because the EMG only tests the lower motor neurons. In fact, instead, TMS, transcranial magnetic stimulation, provides information about the functioning of the upper motor neurons.
One last question, Dr. Paganoni, because I know your schedule is tight, but there's been a couple of folks in the chat that has asked about nutrition. Is nutrition important?
Yeah, I would say that nutrition is obviously important for everyone's, functioning. I would say that, for in general, for people with motor neuron disease, well, first of all, some people have a hard time with swallowing. So that's a different topic. It's more, being safe with swallow. If people develop something called dysphagia, obviously we need to make sure that they can eat foods that they are safe to swallow, because the risk there is to develop pneumonia if you don't do that. So that's one topic. But then in addition to that, we in general, there is some evidence which is still being worked on, but more people are doing, research on this, that losing weight could actually be detrimental in people with motor neuron disease in general, and that's because you don't want your muscles or your body to feel like you are sort of under kind of so-called starvation mode. If you go on a drastic diet, like the kind of the metabolism of the whole body changes. And so we try to recommend people not to lose dramatic amounts of weight, again, unless it's medically indicated for something else. I'm just saying people who are, sort of, kind of with a regular, start with the regular weight. I mean, we tend to suggest not to lose too much weight. I see, and I'm sorry, this is, I really, it's wonderful to see the engagement. It's a little bit too fast for me to read all the comments, the wonderful comments that are coming up on the chat. So I'm not sure I can keep up with.
There's the encouragement, Dr. Paganoni. I'm sure you will like to maybe try to find another date on your calendar at some
Absolutely.
point that we can get back together.
Absolutely. I would love that. Thank you so much. Thanks everyone for being here today.